Okay, hi, this is Brother Wolf, and this is HS 285. Tonight's group is Group 8, and they're going to talk to us about CMS, the Centers for Medicare and Medicaid Services. And so I believe Haley's going to start, and whenever you're ready, Haley, feel free to go ahead.
Okay, so like Brother Wolf said, we're doing the Centers for Medicare and Medicaid Services. I'm Haley, and then our group consists of Braden and Josh. So some history behind Medicare and Medicaid is that Medicare was signed into law on July 30th, 1965.
Haley, I'm sorry to interrupt. Are you trying to show the slides? Because I can't see them.
Oh, you can't? Okay, hang on a second.
Yep, now it looks like it's going to work. Yep,
Okay.
looks great. Yeah, now I see it. Looks great.
Okay, perfect. Okay, so some history behind Medicare and Medicaid is it was signed into law on July 30th, 1965 by President Lyndon B. Johnson. Um, at the bill signing ceremony, which took place at the Truman Library in Independence, Missouri, former President Harry S. Truman was enrolled as Medicare's first beneficiary, and he received the first Medicare card. Johnson wanted to recognize Truman, who in 1945 had become the first president to propose national health insurance, an initiative that was opposed at the time by Congress. Medicare is an amendment to the Social Security Act of 1933. The Medicare Modernization Act was also signed into law on December 8, 2003 by George W. Bush. And what this did is it added an outpatient prescription drug benefits to Medicare. And then Medicaid was also signed into law on July 30th, 1965 by President Johnson. And it was also an amendment to the Social Security Act. And then in 1977, the Health Care Financing Administration was created to administer Medicare and work with state government to administer Medicaid. And then the HCFA was later renamed what it is today, which is the Centers for Medicare and Medicaid Services. So there are a couple different components of Medicare. There's Part A, B, C, and D. So Part A is hospital insurance, and this consists of inpatient care in hospitals, skilled nursing facilities, hospice care, and home health care. And then Part B is medical insurance. So the services from doctors, outpatient care, home health care, and durable medical equipment are all covered in Part B. Then Part C is just the Medicare Advantage. So this includes all the benefits and services of both Part A and Part B, and it usually includes prescription drug coverage. It's run by Medicare-approved insurance companies. And then Part D is prescription drug coverage, and it helps cover cost of prescription drugs, and it may help lower costs and protect against higher costs in the future. And then there's some different components of Medicaid. These include doctor's visits, hospital, which includes inpatient, outpatient stays, long-term services, mental health care. There's some necessary medications, preventative care like immunizations, mammograms, colonoscopies, and others, prenatal and maternity care, and then vision and dental care for children. And now I'm going to turn the time over to Josh.
Alrighty. Thanks, Haley. Alright, so what I'm going to be talking about when it comes to Medicare and Medicaid is both the federal and state-specific issues that are involved with Medicare and Medicaid, and just a little background. It's Medicare that has federal involvement, whereas Medicaid, which has federal and state involvement, based on the funding. Medicaid is primarily funded by federal, the feds, and also the state. But onto the issues. Federal issues for both. Both are a large contributor to our national debt. Medicare and Medicaid incur lots of, it costs a lot for our nation to support these systems. Total Medicare spending continues to increase every year. It increases by small increments every year, but nonetheless, 3 or 4% when it comes down to billions and trillions of dollars, it's still a lot. It's a lot and a lot of money. 2012 to 2013 increased from 3 to 4%. of our national debt, which it's a big chunk though. Rising healthcare costs as well, that's a federal issue. An aging population. Medicare, one of the qualifications to be a beneficiary of Medicare is you have to be older, and our national age, or the national age of our population is increasing. Also dual eligibles, which means, definition for that is those who qualify for both Medicare and Medicaid. They comprise 39% of both Medicare's and Medicaid's costs. These people have high needs and they're extremely poor. And like I said, a large percentage of those who need Medicare and Medicaid are those who are dual eligibles. Some state-specific issues with Medicare and Medicaid is the fiscal year 2012 spending plan, and definition of that is allotted amount of money spent on the program every year, which drastically cuts benefits to the disabled and those who need it. So this law, or this plan, was placed into play in 2012 and basically gave Medicare and Medicaid a budget and gave them a certain amount of money to spend every year. And because of that, a lot of people have been, I guess in a way, shorted care, not given care, because they can only spend so much on Medicare and Medicaid, and that's an issue. Also, HCBS, which is institutional bias of home and community-based services. Basically, what that is you have to be part of an institution or considered an institution to receive health care. And to be in an institution or be considered an institution to receive Medicare and Medicaid, you have to be on a waiting list. And there's a statistic that says 300,000 people with disabilities are on these waiting lists. So there's a large amount of people who are just waiting to be considered an institution base so they can receive Medicare and Medicaid. Also, there is drastic reduction of funding for program services, so that kind of goes along with the fiscal year 2012 spending plan. And also, provider reimbursement rates for physicians are very low. Basically, I mean, it just says what it is. Physicians aren't getting reimbursed completely for Medicare and Medicaid covering their patients or whatnot, and they're being shorted. But moving on, who are the beneficiaries of Medicare and Medicaid? For Medicare, old people. Well, more specifically, those who are 65 and older. People under the age of 65 with certain particular disabilities, and specifically people with end stages of renal disease. Medicaid is a little bit more specifications as to who qualifies, who's a beneficiary. Those with limited income, particularly families with children. Infants who are born to mothers eligible. Children 6 and under, pregnant women whose families are below 133% of the federal poverty level. SSI recipients, which stands for Supplemental Security Income recipients. Those who receive adoption for adoption assistance or foster care, and that's Title 4E of the Social Security Act. And then some people with Medicare as well, so the whole dual eligible concept. Next slide. How are these funded? I kind of mentioned it before, but Medicare is strictly a federally funded health insurance program for Social Security beneficiaries, and Medicaid is federally funded and state funded as well, through standards set by each state by the CMS. The government pays for 57% of costs, and states cover the rest. So, Braden, if you want to take it from here. Great.
Yeah, sounds good. Thanks, Josh. So, I mean, if we look at this, the Medicare Trust Fund, I mean, it was really interesting to do some research on this. As you can read, the board is required by law to issue annual reports on the Medicare Trust Fund. And so, what I looked up 2014's annual trust report, and it was 280-something pages long. So, I mean, they are very thorough with what they do. They make sure that funding is always taken care of and they know where it's coming from. Um, I thought this was interesting. The Medicare program is the second largest social insurance program in the U.S. So it's with 52.3 million beneficiaries and total expenditures of 583 billion in 2013. And another thing, in 2011, it was 48.7 million people, and it was also the expenses for that was 549.1 billion. So I mean, as we see the years go on, we're seeing the costs grow, and like Josh said, it's because of all the baby boomers. We're seeing more people getting older that are requiring this Medicare. Um, Another thing that I saw when I was doing some research, a couple of like what I talked about was Medicare is paid through two trust funds accounts held by the U.S. Treasury. These funds can only be used for Medicare. And those two programs were the Hospital Insurance Trust Fund, and the second was the Supplementary Medical Insurance Trust Fund. So, I mean, the trust fund is there, but if we go to the next slide, we'll find out how much longer that'll last. So it's projected to become bankrupt eventually. I thought this was interesting because of President Obama's Affordable Care Act. It actually has extended another 2 years. It used to be 2024 when it was going to be depleted, but now it's actually going to be depleted in 2026. There was a couple of other websites that had different numbers, but this was the most consistent year I could find. But it was also another reason why that it extended was prices have lowered because of economic recession and other fundamental changes aimed at reducing waste and improving health outcomes. So I mean, because we're always trying to improve and make things cost lower, that's also helping this trust fund last a little bit longer. So I think the next slide, that's all we have for you. Our next slide is our works cited page, so that's it.
Excellent. Good job. Let me ask you, did you guys happen to come across who heads up CMS? Kind of it seems like the person who heads it up, it changes sometimes frequently. And the reason I bring it up is there'll be a specific question about this. And if you, as well as those listening to the recording, if you listen to last night's recording, which was Group 7, and they talked about HHS, CMS is one of the major departments within the Department of Health and Human Services. And HHS is headed up by the Secretary, Sylvia Matthews Burwell, but the administrator for CMS is also a very important post. Did you guys come across that by chance?
I didn't. Haley, did you do that?
I didn't either, actually.
So,
But the administrator.
I'm going to type it in here. His name is Andy. He's the acting administrator. So Andy Slavitt is the acting administrator currently. It was Marilyn Tavener before, so you may have heard that name. But just make note that Andy Slavitt is the current administrator for CMS, because you'll probably get asked that question. So good job. One thing, if you could go back a few slides, you talked about the funding. One more, I think. I'm sorry, one more. Yeah, so, and this is true, that Medicare is a federally funded health program. Medicaid is kind of a combination of federal and state, right? Do participants, so if you're a Medicare beneficiary, let's say you're 65 or 66 and you now have Medicare, do you contribute to the funding of Medicare? So do the beneficiaries or those individuals who have Medicare, do they contribute? financially?
From what I read, I didn't come across anything about that in my research. Um,
So they actually do. It's an important concept that it's true that the government funds it, and when we say government, you can insert my name and your name and everyone else's name, right? Our taxes. But individual beneficiaries, when they sign up for Medicare, also have a monthly premium that they have to pay. They have co-pays, they have co-insurance, and those sorts of things. But they also pay a monthly premium. And depending on what they choose and what program they choose, you guys mentioned the Part C. Which is the kind of the Medicare choice. It's kind of like an HMO Medicare, whereas Medicare A and B is more your standard traditional Medicare fee-for-service type of funding. But in either case, the beneficiaries do pay. So just keep that in mind with the funding. And go back another slide for me. So I'm glad over here on the left you've put, this is a really good slide, I think, for the class. And by the way, this topic is a huge topic, right? You guys did a good job in covering the general requirements, not getting too detailed, because you could spend a lifetime trying to learn about Medicare and Medicaid. And it's a very complex topic. It's always changing. In this class, it's just an introduction to healthcare class. So this presentation, I think, was spot on. It covered the topic at the right depth to kind of give you a general idea and to give you an idea of where you can go find out more information. And as you proceed in your career and in your education, and actually even if you don't go into healthcare, you'll learn a whole lot more about this either with parents or grandparents, and eventually you participating maybe in one of these programs. But Medicare is typically, you're absolutely right, it's typically older than 65, but it's important, the second and third bullets that you put there, that it's not just those over 65. You can be under 65 if you qualify under kind of a disability rule that you guys talked about a little bit, but also end-stage renal disease. So those patients, almost any patient that you know that's on dialysis or is end-stage renal disease, if they're not Medicare when they're diagnosed, they will become a Medicare beneficiary, regardless of their age. So, and Medicaid is absolutely right. You've listed that it's generally those who has to do kind of more with an income level or a poverty level, a certain level there. But then you also get the SSI recipients, which are those that may qualify for certain disabilities. So excellent job. And go back another slide. One more. Okay, this is good. And then one more. Yeah, so this slide, I wanted just to highlight this. This is a really important slide to know, and not necessarily that you have to know all the details under each of these. You should know them generally. You should know that Part A is, generally speaking, hospital insurance. It is broken out for you there, so that's good. You should know that Part B is generally what's known as medical insurance, but that's typically the outpatient care, home care, services from doctors. So when a Medicare beneficiary goes and sees a doctor, it's paid under Part B. So Part A and Part B is kind of known as the traditional Medicare. Part C is this Medicare Advantage, or some people call it Medicare Choice, and that's typically an HMO type company that gets approved to have that kind of insurance. So you choose as a beneficiary either Part A and Part B, or you're going to go the Part C route, generally speaking. And then Part D is prescription drugs, and that's the newest part of Medicare. So I'm glad you have this is a good slide. I just wanted to highlight it and let the class know that this is kind of an important slide. And then go back one or two more. Let's see. Oh yeah, and then this is good just to know. I think this was your first slide with detail. This is good to know that in general, it was signed into law by President Johnson in 1965. And that's kind of a key date and a key person to know that that's when this all started. And it started small, right? It started with just certain beneficiaries, and you've listed some of these amendments. It's not essential that you memorize the dates of these amendments, but I think it's important at this stage in the class and maybe in your education that you understand that as time went on since 1965, additional aspects of Medicare have been added. And so this Part C and Part D, just I think knowing in general that that the law, Social Security Act, and that Medicare as a program has evolved over time, and Medicaid the same. So, and then I like that you kind of put down HCFA, HCFA. That's what it used to be known as, but it's now known as CMS. So that you may hear that term HCFA, but that's more of a historical term. The name changed quite a few years back. So. Great job, and I think the next slide back is just your opening slide. So yeah, great job. Let me see if I see Kaylin's here. If she has any questions, feel free to use your microphone or enter them in the chat. And while we're waiting to see if any questions come in, if one of you from the group would please post your slides on the group discussion board, and then monitor that site during the week to see if your classmates have any questions.
Okay, perfect. I'll do that.
Okay.
So
go ahead, Ken.
I was curious when you talk about who can benefit from the Medicare, the 65 or older, but then certain people who are under 65. Brother Wolf was talking about dialysis, and I'm not sure what the renal stage disease is. Can you tell me more about that?
Yeah. Well, end stage is renal disease. It's basically a disease that has to do with your kidneys. I mean, basically really bad kidney infection. Those who are almost disabled from it or incapacitated from it, and need assistance. I'm sure there's like some more specific qualities and things to like fall under that category, but I don't know exactly what those are. I just know people with this disease, renal disease, which is basically kidney disease.
So Medicaid is based on income amounts.
Yes.
But so with Medicare, then, for someone who has this disease, do they still base it off of their income? Like, let's say my grandfather is well enough off that he can take care of himself, but then he gets this kidney disease. Then is he automatically eligible for it, or does he have to drain his estate before he can have Medicare?
That's a good question.
Yeah, if you guys don't have any input, I could kind of jump in there. So generally speaking, an end-stage renal disease is a very expensive disease to have. And if you looked at, and this is a little bit beyond what you really need to know, but since you raised the question, if you looked at the dollars per beneficiary, and let's say the Medicare budget I think you guys shared was what, 583 million, or excuse me, billion. If you looked at the proportion of that compared to the number of people who fall into end-stage renal disease, but you look at they disproportionately represent a huge part of that budget, because end-stage renal disease is an expensive disease. You're essentially getting dialysis, which is a 2 to 3 hour procedure, every other day for the rest of your life, and it's expensive. So to answer your question of the hypothetical of your grandfather, there are certain medical criteria that qualify you as somebody who has end-stage renal disease. So you might need dialysis. So some people might need dialysis because they had a crush injury, meaning, let's say they were in an earthquake and they were trapped under rubble, or they got in an accident and they were trapped. The muscle tissue can break down, and that can cause kind of an acute renal failure. But your body will will recover from that. You might need dialysis for a week or something, but generally speaking, you might recover. That's not end-stage renal disease. So just because you got dialysis once doesn't mean you fall into that category. End-stage renal disease does have a whole set of criteria, medical criteria, and then if you meet those medical criteria, you essentially apply for Medicare, regardless of your income. I guess there may be some income questions. If you're a billionaire, you might not be able to qualify, but for all intents and purposes, everyone with end-stage renal disease over a period of time will apply for Medicare, and they will essentially be on Medicare, regardless of whether they're under a certain poverty level. But the group did mention two these dual eligibles. Some people might be eligible both for Medicare and for Medicaid. So that's kind of another topic. But does that answer your question?
Yes, it does. Thank you.
Yeah. If you're really interested in that, if you go to CMS, I was on it earlier. Let's see, CMS.gov.
Mhm.
They have, CMS manages so many programs for the government. You can do a search and you can do ESRD or end-stage renal disease, and you'll find a whole page and just pages and pages of what some of their criteria are, what their policies are, and that sort of thing. If it interests you. One other thing I wanted to ask, and the group might not have come across this, but how does the program run? So let's say I'm a hospital, right? And you guys are hospital administrators. And a patient comes in and they show you their Medicare card. Who do you bill? So, if I come in and I have private insurance and my card says, oh, I have Blue Cross Blue Shield, you bill Blue Cross Blue Shield. For Medicare, who actually runs the program and how are the bills adjudicated? Did you come across anything about how it's actually kind of run? We said that Medicare is a federal program, but do you just send the bills to Medicare, Washington, D.C., USA?
Isn't Medicare kind of like a, I didn't come across this, but something I've heard, because I have family that does like billing, and my wife does medical assistance. I've heard Medicare is like more, it's like a contract with doctors, so they really don't really have to pay much. Wasn't it kind of a loss in money on how it goes out?
So I'm sorry, I didn't hear everything there. You were going in and out a little bit, but I heard you say there's a contract, and that's true. Medicare nationally will contract with private insurance companies to run the Medicare program for a certain region of the country, and so there may be 8 regions, and there may be a western region that encompasses the western states, a north central, a south central, a mountain region, an east, a south. So there's these different regions, and you'll get a private insurance company or a private company that they can compete for a contract, for the Medicare contract, and they adjudicate or they process the claims. So if I'm a hospital in Utah, I don't send my claims, and this is all done electronically now, but you don't send them electronically to Washington, D.C. for payment. You send them to this contracted entity, and those are known as Medicare administrative contractors. The reason I'm bringing this up is Medicare administrative contractors can set up payment policies and coverage policies. Medicare nationally might cover certain things, and they'll have policies called National Coverage Decisions, or NCDs. There's also LCDs, Local Coverage Determinations, and those are policies that are set up locally. Locally meaning this administrative contractor. Now contrast that with Medicaid. Medicaid, you will send your claim. So if I'm a hospital and I saw a Medicaid patient and we did a CT scan and a blood transfusion, I do the medical coding and I send in my bill. And Medicaid, you send it to the state. So each state has a Medicaid program or Medicaid office, and they adjudicate or process those claims. And each state then might have their own unique coverage policy. The reason I'm bringing this up is, you might be an administrator for a hospital in California, and Medicare covered, or Medicare or Medicaid covered procedure XYZ for diagnosis ABC, but you move to Florida and the coverage isn't the same. So you guys have done a nice job of giving us a nice overview of CMS. I wanted to give you a little flavor of some of the complexities. It wasn't required as a part of your presentation, but it's something just to keep in the back of your mind that this becomes very complex very quickly. There's a lot of chefs in the kitchen, so to speak, a lot of hands in the soup, and so you get some complexities and some things. They're just not. It's not as simple as we sometimes would hope. So, a very important topic. It's important that you know about them, and the highlights that I've given you and that the group has given you will be important for test purposes. But more importantly, if you're going to go into healthcare or not even healthcare administration, if you're just going to be taking care of patients or you're going to do something like that, you need to know about this program. So, excellent job. Any last minute questions or comments before I let you go? Okay, I think I didn't hear any, so I'm going to let you go. Great job, and have a good night, everybody.